All right, so our group is presenting COVID-19 induced acute respiratory distress syndrome and prone positioning. So first for the overview and rationale. So as far as the overview is concerned, COVID-19 is a viral induced pathogenic infection. It was introduced in Wuhan, China, and it became a pandemic in March of 2020. Target areas of this virus include the lungs. So there's strong prevalence to respiratory symptoms. This is really prevalent in the ICU. Upon COVID-19 patients, there's approximately 1/3 or 75% who are also diagnosed with ARDs. So COVID has a high prevalence of inducing acute respiratory distress syndrome. Applicability of the protocol. Significant research in regards to the clinical pathway of ARDs is present. However, there is further research that needs to be done for the applicability of ARDs with COVID-19.
So there's a lot of controversy over prone therapy, specifically for the reasons I'm about to discuss with you. So many researchers and providers consider prone therapy to be a last-ditch effort therapy rather than an initial therapy choice for ARDs. Another controversial issue is that risks are associated with prone therapy. They're considered to be greater to patients than the benefit of the therapy itself, such as extubation and the development of pressure injuries. And then there's also significant research regarding standardized ARDS protocols and interventions. But with the newly introduced effects of the COVID-19 pandemic, the applicability of current protocol requires further research for utilizing prone therapy in COVID patients with ARDS.
So for our PICO question, the question itself is, in mechanically ventilated patients with ARDS due to COVID-19, does the intervention of prone positioning improve PaO2, FiO2 when compared to patients who do not receive prone therapy? The population in the PICO is mechanically ventilated patients with ARDS due to COVID-19. The intervention is prone positioning, and the comparison is patients who receive prone therapy versus patients who do not. And the outcome is the improvement of PaO2, FiO2.
All right, so next is research and finding as well as policies. So the pathophysiology overview of prone positioning. So when a patient's in the supine position for so long, some portions of the lung can become exhausted and non-compliant. So by placing a patient in prone position, you can further utilize parts of the lungs that may not be used when the patients are in the supine position. And you can see that in the diagram to the left. It can also help reduce further injury and damage, and it allows for healing of those portions of the lung that may be damaged.
This first study is a retrospective cohort study with its level of evidence is 4, and the sample size was 20 participants. So the primary outcome of this study was that changes in PF ratio relative to prolonged prone positioning, repeated prone positioning, early prone positioning, and late prone positioning, as well as sustained PF ratios following prone therapy. The results in conclusion were, compared with the mean PF ratio prior to prone positioning, significant improvement was found at 1, 7, 12, 24, and 32 hours in patients after the start of prone positioning. There was an increase in the PF ratio when initiating prone positioning, when the PF ratio was less than or equal to 150. However, there wasn't a significant increase in the PF ratio when initiating prone positioning when the PF ratio was greater than 150. So in the next study, the design is a retrospective multi-center national cohort study, and the level of evidence again is 4. The sample size this time is actually much bigger, with 1,057 participants, and the measurements were secondary outcomes on the ratio between partial pressure and fraction of basically PF ratios, ventilatory ratio, and the primary outcomes of the study being ICU and hospital mortality. The results in conclusion were that overall prone positioning led to a significant increase in PF ratios, which was approximately 98 versus 158 milligrams of mercury, which was followed by a subsequent significant decrease with resupination. On average, the PF ratios after resupination remained significantly higher as compared to baseline values.
All right, for the next study, this is a quantitative uncontrolled clinical trial, which is level 4 evidence. For the study description, 44 adults in Sweden were observed. They underwent 5 sessions of prone therapy. Each session lasted about 12 to 17 hours being prone. The primary outcome for this study was an increase in the PaO2/FiO2 ratio. And then the secondary outcome was a 30-day follow-up that looked at mortality, discharge, and if the patient was still in the ICU. For the conclusion of this study, the research initially showed that the PaO2 and FiO2 ratio in adult COVID-19 ARDS patients was consistent over repeated prone positioning sessions. So overall, it did improve. And then as far as the secondary outcome, further study is required to determine the mortality. And at the 30-day follow-up, 27% of patients were still admitted to the ICU, 45% were discharged, and 27% had died. And improvement in PaFiO2 was 82%. This study has a statistical significance of P is less than 0.001. All right, for this study, this is a cohort study with level 3 evidence. The sample was divided into a control and an intervention group. The intervention group who underwent prone therapy was 62, and the control group was 199 individuals. Mortality and physiologic parameters were measured. So the primary outcome of this study was decreased mortality, and the secondary outcome was improvement of physiologic parameters to include that PF ratio. The conclusion of this study was the data supported prone positioning as intervention to prolong survival and improve physiologic parameters, including the PF ratio, specifically for patients who are mechanically ventilated with moderate to severe ARDS. And the significance on this one was P less than 0.001.
Okay, so for this next study, the design was a retrospective observational cohort study with a level of evidence of 3. The sample size had 42 subjects who were critically ill and intubated with COVID-19. And the way it was measured is by assessing the PF ratio before and after initial prone positioning. And then the positive result was defined as an increase in PF ratio above 20%. The results showed that the PF ratio improved from 17.9 to 28.2 kilos with 81 minutes from prone positioning in 36 patients, which had complete ABG data of P less than 0.01. Therefore, in conclusion, the study found that in COVID-19 patients placed in prone positioning, oxygenation improved and better responses were associated with better outcomes. And the significance is right there as P is less than 0.001. And for the last study, the design was a retrospective cohort study with a level of evidence of 3. The group 1 sample size had 23 patients with COVID-19 ARDS, and the group 2 had 145 patients with non-COVID ARDS. So in measurements, the main goal was the extent of changes in PF ratio and static respiratory system compliance after the first session of prone positioning. PF ratio and static CRS were evaluated at 4 different times for each patient, and the differences were assessed between COVID-19 ARDS patients and non-COVID ARDS patients. The results were the majority of the patients with COVID-19 ARDS showed improvement in both PF ratio and CRS after the initiating prone positioning. Therefore, in conclusion, prone therapy was as effective in improving respiratory physiology in patients with COVID-19 ARDS as in patients with non-COVID ARDS, with the statistical significance of P is less than 0.01.
So overall, as analyzing the group of research that we decided to choose, We had cohort studies, retrospective cohort studies, and one clinical uncontrolled trial. Level of evidence included level 3 and level 4. We did see lower levels of evidence, but this could be due to the emergency status of the pandemic, as well as the recent time frame of the pandemic as well. So data significance was based on the evaluation of PF ratios after prone therapy initiation. The length of proning varied between each study and was evaluated at different intervals. 2 out of the 6 studies showed that patients returned to the supine position suffered an initial decrease in PaFiO2. However, the supine value after pronation was still higher than the supine value before initiation of prone therapy. And we did see better results with repeated prone therapy sessions. In all the studies, the p-value was less than 0.05, which indicates statistical significance, meaning that if this study was to be repeated again, we would see the same results 95% of the time. And this was significant when the patients were initiated to prone therapy if they had moderate to severe ARDs, which is around 150 PaFiO2 ratio. And in conclusion, the data that we observed and researched indicates that prone positioning ultimately leads to a significant increase in PaO2/FiO2 ratio.
Okay, so in regards to national protocol, there's a lack of specificity regarding national prone therapy clinical practice guidelines other than the length of time recommended, but absolute contraindications include spinal instability, unstable fractures, anterior burns, chest tubes, patients in shock, and patients with increased ICP. Relative to the studies, we identified these clinical practice guidelines regarding prone therapy were not always applied consistently. Although the length of proning varied from study to study, the average length of proning among all of the studies was approximately 16 hours, which is in accordance with the recommended length as stated by these national clinical practice guidelines. So the World Health Organization says that in adult patients with severe ARDS, prone ventilation for 12 to 16 hours a day is strongly recommended. And here you can also see that the ARDS criteria, which consists of onset within 1 week of a known clinical insult, bilateral opacities on chest x-ray, origin of pulmonary infiltrates that can't be explained by cardiac failure or fluid overload, and impaired oxygenation. And we have mild ARDS, moderate ARDS, and severe ARDS as well. And now we'll move on to local protocol when it comes to clinical practice guidelines.
So the specific facility we decided to focus on is UCLA. So their protocol for prone positioning is they also suggest that prone therapy should be considered in patients with a PF ratio at below 150 milligrams of mercury. So this is in between moderate and severe ARDS. And they also say that this should be initiated upon early diagnosis, as well as they should be intubated. They recommend, which differs from the national protocol, that prone positioning should be greater than 16 consecutive hours per day. And then to follow up, an AVG should be drawn within 4 hours of return to supine position. If the patient still meets the severe ARDS criteria, consider proning again. They also suggest to look at Lippincott as far as prone positioning procedure goes. And then they also lay out the complications and considerations. So this outlines hemodynamic instability, inadvertent extubation, desaturation, ET tube obstruction, dislodgement of lines, increased need for sedation and muscle relaxants, facial edema, and the patient may receive tube feeds per MD order.
Okay, so 3 recommendations that we would make for hospitals to more efficiently make use of prone therapy would be by utilizing manual pronation and automatic pronating beds such as the rotaprone, and by implementing prone therapy before a patient is intubated if it can be tolerated by the patient. However, some of the challenges with pronation of intubated patient are those associated with the safety of both the patients and the staff. Although the clinical benefits for prone therapy far outweigh any possible adverse events, healthcare workers must take necessary precautions to avoid situations such as ET tube dislodgement, hemodynamic compromise, disconnecting lines, and pressure injuries, all while maintaining adequate access to the patient's lungs, drains, and chest. So firstly, we'll discuss manual pronation. The primary benefits of manual pronation are the fact that it's cost effective, first and foremost, and there's less of a risk of developing a hospital-acquired pressure injury as opposed to when using an automatic pronation bed. And the fact that by utilizing this method, it requires the recruitment of many staff members, which ensures the safety of the patient will be monitored during the repositioning. So some of the considerations to be made when choosing this method are cost efficiency, primarily. So automatic pronation beds can cost up to $1,000 per day to rent and can be associated with more commonly with pressure injuries. Implementing manual prone therapy results in a cost avoidance of approximately $78,000 per patient, largely attributed to the prevention of pressure injuries. So secondly, we recommend the use of the rotoprone bed. So aside from the cost of using this comprehensive machine, which is pretty hefty, it makes for an easy and efficient way for healthcare workers to pronate patients. Most importantly, it allows for more control in managing the ET tube and invasive lines. Using this bed reduces the stress of the labor necessary to prone patients for staff members and reduces musculoskeletal injury. This bed also allows for movements to various angles to allow for mobilization of secretions in order to decompress the patient's lungs more efficiently. Some important considerations for this recommendation are that it only requires the assistance of 2 healthcare workers opposed to 6 to 8 as seen with manual proning, and it's also less likely to disrupt workflow for staff members necessary to manually prone. So our third and final recommendation is the initiation of prone therapy prior to intubation in patients who are able to tolerate this or are not experiencing severe respiratory compromise. So early initiation of prone position is effective in increasing oxygenation via pulse oximetry and PF ratios and reduces the risk and can prevent the need for intubation. This intervention also requires less effort on staff due to the fact that many non-intubated patients can assist with pronating themselves. So some considerations for this method are that it's cost effective as it can reduce the need for expensive and invasive procedures such as intubation. But as previously mentioned, it should not be used in the event that patients are experiencing severe respiratory compromise.
Okay, so in summary, so we developed the PICO question in mechanically ventilated patients with ARDs due to COVID-19. Does the intervention of prone positioning improve the PF ratio when compared to patients who do not receive this prone therapy? We gathered information from various resources, including 3-level cohort studies, 3 level 4 retrospective cohort studies, and clinical practice guidelines from the World Health Organization. And all that research concluded that prone therapy improves PF ratio in patients with ARDs secondary to COVID-19. We also collected data from our local hospital, the Ronald Reagan UCLA Hospital, and their guidelines support the use of prone therapy as well in patients who have decreased PF ratios less than 150 millimeters per mercury, And therefore, in conclusion, the research data from our studies and the CPGs and local hospital guidelines concluded that providing prone therapy is an effective way to improve PF ratios in mechanically ventilated patients with ARDS secondary to COVID-19. So for financial implications, as discussed above, the rotoprone bed is $1,000 per day if the hospital chooses to rent it out. There's also an increase of pressure injuries, and that is because patients on rotoprone bed are not easily accessible for repositioning as compared to the standard beds. And so if a patient develops the pressure ulcer, that's going to lead to an increased length of stay, which causes of an increased cost as well. So therefore, the manual proning is the most cost-effective way because you have a decreased risk of developing a pressure ulcer. And finally, for further study, future studies should have a larger sample size. That way we can have a more accurate data. They should all include control groups that consist of patients in the supine position. That way researchers can confirm that results are from the prone therapy. And studies should not have a high amounts of exclusion criteria. That way we can allow for an increased sample size, which can result in more accurate data. And then finally, studies should be conducted in the US. And that is only because due to the applicability of outside US may vary depending on the federal and local guidelines. And thank you, that concludes our presentation.